Doc. This morning we're going to use minimally invasive surgery to correct a chronic ulceration in the patient. Minimally invasive surgery lends itself very well to ulceration surgery and to relieve pressures on the foot. If you see the patient here, you can see his foot. He has a chronic ulceration here. He is a type 2 diabetic, and this ulceration has been infected several times. Well, we're going to treat this. We're going to basically go back in the distal diaphyseal bone, make a wedge osteotomy, and actually push it. This will actually elevate the fifth ray. We're going to do a through and through osteotomy. We're going to take more on the dorsal aspect than on the plantar aspect. But we're all going to go through and through to allow this to elevate. So it's a very simple, quick surgery. We're going to start that now. To start the surgery, basically you're going to use your C-arm to pinpoint exactly where you want to go. You can see, if you look at my C-arm here, away from the vascular structures, and this is all the way down the bone. It's a very simple stab incision, so you're not going to hit anything vital here. Once that's performed, you'll take a small rasp like this. This is what you do your soft tissue release with. Hit in the same plane you did there, and you're going to go across the top of the bone here. If you see the C-arm, you can see where I'm at on that. You see the plane I'm making? One thing you may want to know too, if you look at my hands, I have protective gloves on here that do not allow radiation to hit my hands. Okay, then we turn that over, get on the plantar aspect, and release that too. You can see down the C-arm too. You see where I've released. So you don't want to go into this inner space. You just release what you have to. So that's your soft tissue dissection. You see there's no bleeding, but you're not really any kind of vascular structures. To do our osteotomy, we're going to use a straight Ischen burr with a saw. This allows for a slow speed, high torque way to do the osteotomy. You basically place this directly in the path where you just did your soft tissue release, so you're not going to grab any soft tissue. Look at your C-arm, you can see your exact spot. We're going to angle this a little bit like this, sort of a little bit back proximal, and we're going to do a wedge cut straight down. Now when you make the cut, you don't have to go real fast. It's a real slow cut, so you don't even want to really hear the actual instrument. So you're not going to have a buzzy sound or anything like that. You need to do slight reciprocating motions. At this point, I'm about halfway done with the osteotomy. I'm going to make a little bit of a bigger wedge on the top and continue with the same plane. If you look, you can see this while I'm doing this. I'm actually doing this under fluoroscopy, so I'm monitoring where I'm at. That's a live shot right there of the osteotomy being performed. This is done a little bit more proximal than we do for a tailor's, so we get a good amount of elevation. His foot type will require that. So now I'm working towards the lateral aspect of the osteotomy. And when you feel this go through, you can actually feel it go through. Just have a little bit more left. It's not a race, you can take your time. So now I'm all the way through my osteotomy. To ensure that you are through, you take advantage of your C-arm and basically retract back on your osteotomy. You can see how that's separating apart. Let me let it drop. You can see it separate apart. So that we know we're through our osteotomy. The other way too is to also check with the plantar aspect to make sure you're going to get elevation of the bone. In his case, we are. I can feel that raising up there. You may get when you're doing this, you may get a little bit of bone paste out. You don't want to get much of that out because you do want some of that to stay in. What I'm doing here to make sure I'm through, we retract, basically retract until you can see, but you can also kind of manipulate the osteotomy. You can feel this osteotomy is through and through. So when he stands, this bone is going to raise up and take the pressure off of that fifth med. If you look in front of his foot now, come over on this side. You can see when he walks, when we get him in a neutral position, when he walks, it's going to push up on that metatarsal like that. So this is something the patient ambulates on. We'll address this with a Una boot directly to the skin and then just a normal dressing. This is something I want to show you. If you look at the C-arm on the GoPro here, if you see me manipulate this, this is our osteotomy. You see through here, You can see if you push up, you can see how that metatarsal, see how it's elevating up. Watch this, I'm going to push up on the bottom. See how that's elevating up, so it's going to heal in that position right there. But it's a kind of an oblique view because it's hard to get the patient in the exact position to show you this. But if you see right there, you can see that view right there. You can see our plantar cortex, how it's now, we're going to get dorsiflexion in our cortex here. I just want to show that to you. This is a continuation of our minimally invasive correction of an ulceration on a patient with a 5th metatarsal ulceration, stage 2 diabetic. Let's look at the bottom of this figure. You can see now this is 6 weeks later, and the ulcer, for the most part, has healed. There's a really small spot left here. This was a very painful issue for him because he's not really neuropathic. And so this is 6 weeks. You can see our incision site here. Not very visible because minimally invasive leaves from really good scarring. So what we did with him, we kind of did an osteotomy and wedged it on the top to pull his 5th metatarsal up. So he had quite a bit of trouble with this, and he's doing a lot better. And minimally invasive surgery does real good with these types of ulcerations. Here's our patient. I want him to talk to you. Mr. Daniel, describe to us what kind of pain you've had with this and how long it's been bothering you.
I've had this pain over 41 years, and it has been a throbbing, burning sensation like standing on a fire coal.
Right. And before you were diabetic, it would hurt you too, right?
Before I was ever diabetic,
yeah,
it hurt also this very same way. And what it did, it would form a great big callus over it. And I'd have that, I had doctors and stuff, I've had one to go in and burn it.
Right,
and it came right back.
Right.
So claiming it was a plantar's wart, and Dr. Peacock said it was not, and he did it, and like I said, day one, I've had very little pain.
Right, so that's a good testimony. So with minimally invasive surgery, you don't get a lot of pain, and if you notice, we only had him in the surgical shoe a couple of weeks. He's been in his regular shoe for the most part during his post-op here. So we've been able to take care of this problem with him and get rid of the pain, and also get rid of the ulceration, which could be, can be limb-threatening for a diabetic patient. So we're glad we got rid of his pain, and we're very happy that we got rid of the ulceration. So everything seems to be healing well. The bone is healing well. The way we cut this bone, we did a real neat cut with the Eichenberg, and we didn't even get a lot of secondary bone healing because I left the plantar cortex intact. So when we stood, basically it basically closed down our osteotomy, and it really has healed really good without a lot of even secondary bone healing. I'll show you that over here. Here's our X-ray here. This is 6 weeks. You can see our cut right here, and you can see there's not even a lot of secondary bone healing because we did leave the plantar cortex intact, and so we got a good compression of that osteotomy.